And now it's to our next session on innovation in healthcare. It's a delight today to have Merryn, Stephanie and James as part of our panel as we talk through a number of challenges in healthcare and innovative models of healthcare delivery. As you know, there are so many challenges that people with intellectual disability experience in accessing healthcare that meets their needs. There are often gaps in service provision, and often our services are not sophisticated enough to meet the complex needs of many individuals across multiple facets of healthcare and other services that are required to support better healthcare. So it's an absolute pleasure to be having this panel today and be welcoming our speakers. I'd like each of our speakers, Merryn, Stephanie and James in that order, just to introduce themselves and to tell us a little bit about their background, who they're representing and the context in which they work. So over to you, Merryn.
Thank you, Julian. As you said, my name is Merryn John. I'm the District Manager for Disability at Western New South Wales Local Health District. I'm a social worker by background, and I've spent my career working in health with a particular passion working for vulnerable populations, specifically aged and disability. I've been fortunate to be a part of a lot of disability initiatives, including the transition to NDIS, the establishment of disability inclusion action plans, and then importantly, the implementation of specialist intellectual disability health teams in both South East Sydney and Western New South Wales Local Health District. I've been out in Western New South Wales Local Health District for 4 years, and I've really enjoyed applying my skills and experience in the rural context. I guess out in the rural areas, there's a lot of room for innovation. I guess we need to consider things like the geographical need for our facilities and our client groups. And so I guess it's really important that we're able to be innovative in the services that we provide to meet the needs of the communities that are often not considered or have some complexities to receive the same supports that our metropolitan services are able to provide. Thanks, Julian.
Thank you so much, Merryn. And now it's even further west. Over to you, Stephanie.
Thanks, Julian. My name's Stephanie Searle. I'm acting as the Service Manager with the SA Intellectual Disability Health Service here in South Australia, SAIDS for short. I'm an occupational therapist by background, with a background working in inpatient rehab settings primarily, and brain injury rehab, moving into the intellectual disability space more recently over the last couple of years. SAIDS is a statewide service, so we cover all of South Australia. We're based in the north of Adelaide, but we'll go and see patients into regional areas and do outreach clinics a few times a year. I'm obviously biased, but I think that occupational therapists bring a lot to this work and this space, and a very strong advocate for the role of allied health in these health services supporting the needs of people with intellectual disabilities.
Thank you so much, Stephanie. Now we're flying way over to the far east. Over to you, James.
Thanks, Julian. So yeah, my name's James Smith. I'm a psychiatrist and I specialise in intellectual disability mental health. I work in a statewide service in New South Wales. So it's called SIDMOS, and what we do is consult other teams who are working with people with intellectual disability mental health. Today, I'm going to also represent the kind of wider services in intellectual disability at Sydney Local Health District, where I work.
Thank you. And James, now we're with you. I think we should start with you. There's a raft of service innovation occurring in Sydney Local Health District. I wonder if you could tell us a little bit about what's happening in your patch and how you see some of these initiatives have come about.
Yeah, absolutely. So there is a lot going on in Sydney Local Health District. It's been great to work here. The first thing I want to talk about is the service that I work in, which is SIDMOS. So it's the statewide intellectual disability mental health outreach service. And that is a hub, an intellectual disability mental health hub that was set up really from a ministry funded special project after a lot of advocacy and thinking about how we could serve the needs of the population across the state. So that was set up around 2019, 2020, not by me, and I took it over a bit later on. The model is innovative in itself, as we try and work with the consumer whilst doing a consultation model to the teams. What we've found is that across the state, there's lots of teams that work with people with ID, but the specialist knowledge can be lacking. And so people will come to us and ask us, what do you think the intellectual disability component of this mental health presentation is, and how can we improve things? When I took over the service, we had a lot of referrals, but one of the things that we needed to do was improve how we worked with the consumer. And so we launched a new co-designed model of care where we got people with intellectual disability to come and tell us what they would prefer. And it was very clear from the beginning that there was no decisions to be made without them involved. And actually, they wanted to be involved in all of the reviews. So from a consultation model, that was where we had to change and make sure that we focused primarily on seeing the person with intellectual disability and then consulting to the team once we'd got their opinion of what was happening. So the other thing that we do in CIMOS is think about the multidisciplinary team. And so it can be very fractured care for people with ID. That's very well known, and people have reported that. And so we have psychologists, psychiatrists and nursing within the team. And they can work, that means we can work well with all the different areas, so particularly with the NDAS, and so we can provide advice to behaviour support as well as to psychiatrists. So having all those different team members has been really helpful. Thinking about the other services we have here, so Sydney Local Health District has kind of understood very well that if you provide great community care for people with intellectual disability and support people when they're in hospital, you're going to get better outcomes and you're going to get people living more healthy in the community. And really, there's a lot of data that shows that is going to improve admission rates and hospital rates, and ensure that once people are out and well, that they stay well. And so what they've done is put in disability inclusion strategy, disability inclusion and strategy manager, who has, during the period of COVID, actually done a really interesting project where he worked alongside the NDS providers of the people within the district here, and supported them to kind of capacity build in their own way, and linking with us so that when someone was in hospital with intellectual disability, they were able to communicate very well with the group homes and support them. And so you can imagine during COVID, that period was very difficult for this group. And so these networks got set up and are now in existence and carrying on. So what we're looking at now with those is about how that works with new things that are coming along, like influenza, and how the district works kind of outside of its scope of just providing healthcare, but how it works with the social care elements as well. The other services we have are disability services. So there's a strong rehab focus here, and I think that that's very important for people with ID. That kind of longitudinal input from a range of specialists, which rehab physicians are very good at and rehab teams are very good at, has really taken intellectual disability under its wing. And so we have intellectual disability mental health services here, which are part of those rehabilitation services. And we have formed a specific clinic for people with ID and mental health conditions, and that is served by a specialist psychiatrist and a social worker and the rest of the rehab team. So if you've got an ID in Sydney Local Health District, you get a lot of people seeing you at once, right? And I think that's where it's really key. And that particular, getting that in down, firstly on paper, presenting it to the district, and then getting it through to a working clinic has taken a lot of innovation to try and convince people that this is a great way to work with people with ID, and actually you can't do it alone. Finally, we have the specialised intellectual disability health team here, which is again an NSW Health kind of movement to bring specialist care to people with ID. And so we have our Strides team here, and they work across the lifespan. So again, there's a paediatric component and an adult component who've done lots of work in pushing forward ID health within the district. Overall, the innovation has been bringing lots of different people together, and being able to work with external providers, and that's where Sydney Local Health District has done well. And the second thing is that we all, between our ID teams, are quite flexible. So we have to, when you have your model of care, there's going to be someone that comes in that doesn't really meet the criteria for one, and then we can work together and push forward. So we have had good outcomes because of that.
Thank you, James. So you've highlighted a number of initiatives that are partly there because there's been expert planning, understanding the population needs, understanding the principles that service provision is likely to improve the efficiency of health services. And most of that that you've outlined is funded by the local health district itself and well supported by experienced clinician leads. But then you've also highlighted the SIDMOS, the Specialist Intellectual Disability Mental Health Outreach Service that you lead, that is funded at a state level as a tertiary intellectual disability mental health service. So there's investment also at that state level, which has really made these things happen. So thank you for sharing those areas of innovation from Sydney Local Health District. Stephanie, if we could fly right over to Adelaide now and hear from you about the service innovation occurring in your patch and how it's come about.
Thanks, Julian. The last few years here in South Australia have seen a lot of change in this intellectual disability health space. The service was previously known as the Centre for Disability Health and was originally established to support the transition of people out of institutional care. And then the service underwent another transition with the implementation of the NDIS here in South Australia. So the service was realigned between government departments at that point in time. It had previously sat within Human Services and it came across to Health at that point. And with that transition, there was an independent review commissioned and completed by a number of key stakeholders across the state to really provide some advice around what the model of care for the service should look like moving forwards. And what we've been in the process of implementing over the past 5 years is our current model of care, which is an incredibly multidisciplinary model and something that we're very proud of here in South Australia. We're very fortunate to have a team of a variety of professional disciplines here in Adelaide. We've got medical consultants from a number of backgrounds, including rehabilitation medicine, psychiatry, neurology and general practice. We've also got nurses and allied health within our team, including occupational therapy, speech pathology, pharmacy and social work. And that gives us a really comprehensive range of skill sets and perspectives for when we're trying to unpack what's going on for an individual that's been referred to the service. We're really able to have a look at it from a variety of different angles and everyone's able to sort of pitch in with their thoughts and ideas about what might be going on for the person. This model also allows us to work really opportunistically. We're all physically based within the same clinic location. So, taking into account part-time days and things like that, for the most part, if a patient's here seeing somebody for an appointment and let's say they're with the neurologist and she's identified something that is problematic with their wheelchair, she's able to just pop into the OT and say, hey, have you got 5 minutes to come and have a quick look at Susie while she's here? She's really uncomfortable and having some challenges. So it just gives us that real flexibility to be able to work as a team, but also try and offer the best that we can for these clients. One thing that does often cause confusion is that people will often have a team of NDIS-funded allied health therapists involved in their care. But what we find is that we're really coming at things from that health perspective and that health lens, which is often slightly different to what their long-term NDIS therapy team are working on with a person. And our team more broadly are able to provide some advice and recommendations back to their existing longer-term services. We don't stay involved indefinitely, but we're able to try and optimise the situation and then hand our recommendations back to their general practice team and their other therapists and primary health supporters. It also allows us to provide supporting evidence to the NDIS around a person's needs, particularly when gaps in funding might be contributing to the situation and some of the reasons that's brought them into our service or a hospital setting over the recent period of time. Another area of innovation that we're really proud of here in Adelaide and at SAIDS is our healthcare access service. So as of February of this year, we've been able to establish a procedural sedation service in conjunction with Modbury Hospital. That's supported by an anaesthetist, and one morning a month, we're able to see 2 patients through that list. We've been able to partner with a number of different services so that when that person comes in, we can try and do as many things for them as possible. We're able to do blood tests and vaccinations. Our special needs dental unit here in Adelaide partner with us, and they come and provide a general check and very simple intervention for the person while they're sedated. We're also able to access imaging, and just last month did our first MRI under sedation for a patient with ID. And we've also got access to podiatry service through our connections with the rehab team here in the north of Adelaide. So again, our multidisciplinary model, and in particular the allied health staff that we have within the team, allows us to facilitate a really coordinated approach to planning the person's admission for their procedural sedation. And we've been able to prepare a number of pre-resources, such as personalised social stories about my trip to hospital. Our nurses are able to go and do pre-consults with the person before they arrive, and our pharmacists are able to provide advice on pre-medication options for our anaesthetists to consider, and other factors that need to be thought about in terms of the burden of polypharmacy in the context of the anaesthetic event that that person's likely to have. So they're just two of our key things, but we're certainly very proud of them here in Adelaide.
So Stephanie, what I'm hearing is that there's strength in that multidisciplinary design of the clinic. You have flexibility to bring in clinicians and experts as needed. That provides that holistic care and that breadth of care that's really required in a situation where someone might have quite complex needs. But there's also some progression of the issue around access to sedation through a newly formed sedation pathway that's taking shape, which is great to hear. And one thing that we really want to see happen at a more general level across the country. So I think the two elements of the models you highlight there are ones that we'd very much hope to see echoed in other parts of the country. And it's wonderful to see that investment through SA Health in that design and delivery in South Australia. Also lovely to hear the birds in the background where you are, really special today, so thank you. We're going to now go to a contrasting situation. And Merryn, you've been tasked with the challenge, I think, of providing supports in healthcare for people in situations including quite remote, ranging from regional through to quite remote situations. I'd love to hear how the service innovation is proceeding with that extra layer of challenge.
Yeah, very happy to share, Julian. I think we're quite fortunate to have a lot of innovation happening in our space. We have two specialist intellectual disability services. So we have our intellectual disability mental health service, which is a district-wide service, and our specialised intellectual disability health team, which James talked about as well, which is also in Sydney Local Health District. And we run the only regional hub which outreaches to Murrumbidgee and to Far West, which I guess just by example is 71% geographically of New South Wales land space. So it's quite a challenge to look at how we provide a model to such vast and a wide range of area space. I guess just by example, our district alone in Western New South Wales, it takes about 9 hours to drive from one side to the other. So I guess what we really need to consider is how we can be innovative to ensure that people in our communities get the same sorts of supports that are available. We have quite a number of clinicians in our district who are very passionate, which has led to a lot of projects and innovative ways of working. So within our district, we have a couple of funded projects. We have our Communication for Safe Care project, which is an information linkages and capacity building project, which focuses on communication accessibility in the healthcare service. And an important component to that is about how we ensure that our health services are accessible for people with intellectual disability. Both of our specialist services have been very engaged in working in partnership with our peri-op services, and we're in the process of building that project and really looking at the work that we can do in that space, whether that be the quiet pathway, sedation pathway, or just general communication accessibility as well. But I might focus a little bit on the specialist intellectual disability health team and I guess the adaptations that we had to make in the rural context. I guess it's a small hub, so it's about 4 FTE with 2 outreaching clinicians, one in Murrumbidgee and one in Far West. So we had to consider how it is that we can meet the needs and physically see those patients when we have such a small FTE. To us, the answer seemed simple. It was telehealth, and that's a very common approach that Western and a lot of the rural districts provide in specialist care. So for us, it seemed like it was going to be achievable. But there were a lot of questions as to whether this was really a feasible way of providing services for the intellectual disability cohort. And there was a lot of, I guess, doubt that we came across as to whether we really should go down this path. I guess what we had seen is that there is a lot of people with intellectual disability had automatically been excluded from access to virtual care, though we also knew it was also quite challenging for this cohort to travel some distance to get to a clinic, and with a small FTE it was also challenging for us to be able to travel out and to get to see these clients as well. I guess, you know, whether that be by road or plane, there are a lot of challenges along the way. So I guess what we did is we had a look at the evidence, and there was some evidence out there. There was some work that had been done by yourself, Julian, and by Dr. Delves, who works within our district around telehealth in the intellectual disability space, but there wasn't a lot of work out there. So we decided to give it a go. We felt that this would give us the opportunity to provide equity across our districts. It also gave the opportunity to include key stakeholders that normally wouldn't be able to access a clinic or provide input to a clinic. And as a manager, it also allowed me to access a wider pool of experienced clinicians to ensure that we had the best expertise providing these services in our region as well. We decided that it was important that we didn't just I guess it was important that we were clear about the work that we were doing and that we had evidence behind the work that we were doing. So we did set up a monitoring and evaluation framework very early. Whilst we could see it working, we wanted to ensure that we were hearing from clients and from service providers to ensure that it wasn't just our assumption that things were working well, that we had the evidence that things were working well. We were very fortunate to receive a translational research grant, and this allowed us to do some further work to ensure that we understood that this was a feasible way of providing a service to people with intellectual disability. And that project is underway at the moment and has had some fantastic outcomes in gathering information and further co-designing this process and ensuring that we are providing a service that meets the ongoing needs of our community.
Thanks, Merryn. I really look forward to hearing the fruits of that translational research. And I think what you've done or illustrated so nicely is building in research into that health services system capacity building. You've spoken really well, I think, about the vision for improved accessibility across the range of services that you're providing in Western New South Wales, and then extended that to think, how can we do this through a telehealth lens? And that's really helpful to understand, and that's helping you overcome some of those geographic and access challenges. And it'll be nice to hear how perhaps that could be, or the understandings you come to could be adopted for use elsewhere, given the really great spread needed for many of our services across very diffuse areas. I can't imagine what a 9-hour commute one way might look like. So I think using technology to overcome that is very clever. So thank you. Now, you've highlighted some of the capacity building elements in your service already, but our next question is really about what inbuilt capacity building is there. Are there any additional capacity building initiatives you'd like to highlight before we move back to James and Stephanie?
Yeah, capacity building is a really important part of both the intellectual disability mental health and specialised intellectual disability health teams. And there's lots of things that both teams do around education and resource in local partnered services. And I think the one to focus on that both are very much engaged in is that work with our peri-op services. And what we find is as we engage in that work, it really is a very large project, and there are so many components to that work. We have received a small grant through our district called the Pitchett grant, and we're working to look at how we can use that in the best way to improve the accessibility of access to services. We've also engaged a number of our other projects with the perioperative services. So we're probably in the very early stages, but I guess capacity building has not just been about engaging and providing one-on-one education or group education to our health services, though a really important part, and supporting communication access, perhaps through easy read and so forth, as we develop resources across our district. But importantly, it's been about engaging in those broader projects that we can create some system-wide change to improve the experience for people with intellectual disability. And so a big part of the projects has been both the peri-op project and the work that we've been doing around virtual care in intellectual disability.
Thank you, Merryn. I think you've highlighted nicely how important it is for us not to work in our own little space and to share the knowledge, and to engage in those capacity building projects you've outlined is really critical to make sure that throughout the mainstream service, the health needs of people with intellectual disability are able to be met effectively. So really important parts of your project. James, I might turn to you if I can, to understand the capacity building initiatives that are in Sydney Local Health District.
Yep, sure. So we have formalised capacity building initiatives. We have lots of informal capacity building. Our formal capacity building project within SIDMOS, which is the statewide service, is called Project Echo, and that's been taken up by the district really successfully across a range of areas within mental health. And we are running one in intellectual disability mental health. And so we've ran about 13 series now, and they last for 9 to 10 weeks. And we have about 30 participants in each. Now, the session itself is ran in a way that we managed to have some educational sessions where people can hear about what the updates are, but also have a chance to discuss their own people that they work with, so patients or consumers. So a typical session will be a half an hour lecture from someone who's a specialist in an area. It might be on occupational therapy, on psychiatry, within mental health, and then we all get together after that and present. Someone from the group presents a case to us, in which the whole group can then input to see what things might help, and we put together a report. So it's got a very clinical focus. Now, that capacity building initiative has trained around 500 people across New South Wales now, and what we have really done well at is getting a mix of health clinicians and allied health from outside NSW Health, so thinking about NDIS, and also the Guardian, people from the Guardian NCAT, our Guardian Tribunal. So it's been really useful to have all of those people in the room together to try and understand each other's needs. And this is where, again, that kind of approach has been very helpful to understand everyone else's difficulties, opinion about what's going on for a particular person. And then you can start to make plans which are much more holistic and feasible. So that is still going very strong. We have lots of people applying and creating this for that. The other part is the kind of softer, informal capacity building that we do. The way that we do that is by making sure when we consult to teams that the team are present whilst we're doing our consultation, particularly with the person. One of the huge barriers for people with intellectual disability is about the communication between the system and them and the health system. So we produce easy read information for all of our clients about the service and about their report and what happens and what we've said. That not only helps the person understand, but it also demonstrates to the team how to communicate with the person with intellectual disability. And it's a very simple thing to do. It doesn't take much specialist knowledge to be able to translate something into easy read. And then the person that you're working with suddenly understands. And so it's very clear to us that you get better outcomes once you do that. So that kind of informal capacity building is very important. I will say it remains important to have specialist centres. You need specialist areas where, for example, we have a tertiary, ours as a tertiary referral service. So you want to still have the clinicians there that can provide extra support. But the informal capacity building builds up everyone else in the secondary care and primary care areas to be able to work with someone, and then they can progress up to us as the tertiary consultation. So that capacity building model helps it's worked really well in having a really formal structured approach and also the informal approach.
Thanks, James. I really love the way that you've almost essentially established a community of practice with the Project Echo, bringing together people from lots of different backgrounds to work hard, I think, on some of the challenges. If we understand the constraints within the different areas, then we can certainly, I think, progress and challenge and use that information in our service model. So a really clever approach. I know a really successful program. It's been much appreciated by the participants. So thank you for driving that. Stephanie, if we could go over to you and understand the capacity building initiatives that are part of the work occurring in South Australia.
Thanks, Julian. Capacity building is definitely a priority for us here too, and it's one of our key strategic objectives for the service. We're regularly presenting education sessions both internally within health. We do a range of in-service presentations to our local health networks and acute hospitals, but we've also partnered with a lot of the non-government organisations and primary healthcare providers here in Adelaide to present on a variety of topics, but the recurring ones tend to be working with people with intellectual disability. And more recently, we've also worked with our local restrictive practices unit to be presenting on strategies for reducing the use of restrictive practice and minimising restraint in healthcare and in the community more broadly. We've also got training positions embedded within the service. So this year we've had a psychiatry registrar position within the service, and in the last couple of years we've had a rehab registrar position within the service. And the other bonus that's come about with our procedural sedation service has been that our anaesthetist has been able to have a registrar with him when we run our list. So it's a really fantastic opportunity to try and capture some trainee medical professionals to try and put the seed there about getting involved with this work and try and drive some passion and enthusiasm in that space. We also work really closely with our universities here in Adelaide to try and increase the overall content around intellectual disability and healthcare for this population group. And we're actively working to build our capacity to support student placements within the service in both allied health and nursing. So a couple of key areas that as we're continuing to grow, we're hoping to be able to continue capacity building in that way.
Thank you, Stephanie. I really appreciate you touching on the issue of training, particularly specialists in medical fields, but also opportunities for students to experience placements that expose them and enable them to develop their skills in communicating effectively with people with intellectual disability. Now, both these things, of course, have been central to the government's response with certainly principal support for the idea of developing specialised training pathways in key medical specialties, but also, as you know, developing the core capability framework. Implementing that will require us to have student placements available that expose students to this area of clinical practice. So it's great to see them inbuilt, and I do know that those opportunities, particularly for specialist trainees, also exist in the other health services we're speaking to today. So it's really wonderful to hear of that capacity building in your service. Now, our next question to our panel is really how we know our services are successful. And in that question, I'd also love it if you could perhaps include a reflection on what didn't work well and how it could be done differently if you have that insight to share. Stephanie, given you had the microphone, perhaps we could start with you and then transition back further east over time. But how do you know if your service is successful? What are the measures of success? Are there tips, things you might do differently?
Yeah, thanks, Julian. We're certainly really working at the moment to actively build our research capacity within the service. That's a real priority for us at this point in embedding our model of care. And we've recently partnered with Flinders University here in Adelaide to establish a research lead position that's embedded within our service. So we're actively looking at several research projects that we're hoping will be part of helping us provide some evidence around what we are doing really well and the success of the service. Some of those key areas that we're interested in looking at is around our successful deprescribing rates, ED presentations for people with intellectual disability, the re-referral rates to the service. So obviously if we're doing a good job, we shouldn't be seeing repeat referrals back through the service, but also looking at some qualitative case studies, because I don't think we can necessarily always objectively capture in data the impacts that services like ours and the services interstate are able to have on a person's overall life and well-being and their families and the support networks around them. Some of our reflections thus far around things that have or haven't panned out as we thought they might. Our original model of care included psychology and neuropsychology FTE, and we found that that's been incredibly difficult to recruit to. We've had several attempts at that, and there's obviously a range of factors impacting there, but the NDIS space and the private world, by comparison to public health, is a significant contributing factor, but that's caused us to try and pivot and look at alternative ways of still being able to fill what was intended with that role and those components of the service. And we were able to build in some service agreements with a couple of private psychology providers here in Adelaide who were able to outsource when required some psychology or neuropsychology input. But then we've also kind of reflected further on, well, what did we actually want from those roles and what would those people be able to contribute to the team if we were able to recruit to them? And one of the key areas we were looking at was that behaviour analysis and advice and input around supporting people in that space. And so we're currently in the process of looking at varying our psychology roles to perhaps a specialist behaviour support practitioner role instead, and bringing somebody from that lens into the team to be another piece of the jigsaw puzzle as far as looking at what we can offer and how we can do things a bit better for these patients.
Thank you, Stephanie. You touched on having a researcher in your team. I don't know of any other health service that has a designated research position. I'd love to hear from the audience or anyone in that situation, but this is really innovation. So you're ensuring that your research informs your future developments by building in that capacity locally. I think that's a great opportunity, as are broader research collaborations that can be built around health services work. So we might go to Merryn. We'll fly east in a logical order this time. Merryn, could you talk a little bit about how you know your service is successful and any reflections on what didn't work or could be tweaked?
Mm-hmm. Yeah, happy to. I think I spoke earlier around the importance of monitoring and evaluation, and that was essential as we knew we were doing the model differently to the rest of the state. It was essential that we set that up very early and had a clear plan for monitoring and evaluation to provide the evidence of what it was that we were providing. And I guess I'm going to jump on the research bandwagon and say that research and co-design have just been so important. And I guess having a health service that has space for that research and co-design to happen. And I guess that probably leads me to some of the learnings that we have. And I guess the number one learning for me has been to consider the time and resources required to engage lived experience properly. I think that it can be something that we need to really engage the right amount of effort to do it right. So that has been a really important learning for us, that some of these processes have taken a bit more time, but it's really important that we do invest that time and that we prepare for that in our grant proposals and so forth as well. I guess the other learning is to consider how prems and proms will need to be adapted, and that has certainly been an area in all of our research that we've done, that we've really had to take a step back and look at something as simple as the tools that are used to gather that data and ensure that it is user friendly.
Thanks, Merryn. You touched on the really difficult issue of measurement in this space,
Yep.
particularly when we're wanting to capture the views of people with intellectual disability of their experiences in healthcare. And I know Rima Harrison's group and others are leading some really important work in the PREM space, and it's great that we now have this in view, and we'll have hopefully some tools that may be able to be used more effectively. So thank you for sharing and acknowledging that you have highlighted the additional resourcing required to do co-design research well. This is one thing the Centre is really passionate about supporting, and we will have a researcher network that we're establishing along with tools that we're hoping to highlight for researchers and ways of doing co-design and research well, that we hope to bring to that group in the near future. So thank you for highlighting that as an area of great need. James, it's important that we hear from you. How will you know if you're successful in the services provided? And you can be as broad or as specific as you want, given the raft of services in the Sydney Local Health District.
Yep. So there's a few ways of measuring, and I think everyone here has already touched on what I would say as well. So I won't repeat all of that. The first thing to say is that we did have a very thorough evaluation of the hubs, which provided by the University of New South Wales as part of the funding. I have to say that took a really broad approach and interviewed a lot of people with disability, and so they were able to provide direct feedback. The feedback was very good, and we ended up using a lot of that to determine how we move the service forward. And again, the message was very clear about inclusion. That if we're going to measure how people are following the involvement with services, we really have to ask the person themselves. And it's amazing how many services don't. The response often when we talk about the YES survey, which is a kind of series of questions about it, is to say, well, you could do the carer survey instead. And so what you automatically do is exclude the person from giving feedback. So we really need to learn from that. And when you have a service which asks the person who is actually involved in the care, how do you feel at the end of it, you're going to get much better data. So speaking more broadly about that, what we need to do is start setting up this across the country. So we're trying to bring things together across New South Wales, and there is work being done there. But actually, we have the opportunity now, particularly with the National Centre, to start creating outcome measures that we can record across the country and see what differences are being made. Now, the other thing that we struggle with a lot is that we have a lot of different ways of communicating with people, and we work rurally and see people across the state, as well as seeing people in person in very urban areas. And so we need to think about how we record our outcomes based on how we're interacting and engaging people, because it might be that we need to change. So there's a level of sophistication that needs to happen around the recording of this. At the moment, I don't think we're quite there. The work that's happening is good, but it does need to be a specific focus. And I agree with everyone else that part of this needs to be, so this should be part of the service funding, and so that we have time when we're working with people with disability to see what helps and what doesn't. And, we've got a great platform now to start bringing this agenda really to the front.
James, thank you so much for highlighting that we should be building in the evaluation in all of our new models of service as we're designing them and costing them. We must build in the reality that measurement is important. Those tools and those inbuilt mechanisms need to be there from the start. And at times, as services like SIDMOS require, there would be formal external evaluations, but we must be doing evaluation of our own services well in a way that informs our future iterations of them. Otherwise, we will really struggle to improve the health services that we're operating. And I think all panellists have really highlighted the importance of both the lived experience perspective from the point of view of people with intellectual disability, families and carers, but also the multiple stakeholders you have in your services, around the capacity building initiatives, for example, measuring the impact of those and the growth in clinician knowledge and attitudes and abilities to meet the needs of people with intellectual disability. And then there's the hard KPIs of that Stephanie mentioned. Are people coming back to the service? Is there improved efficiency in healthcare that is gathered from the data that we collect? And to do so, we must have data systems that enable us to identify people with intellectual disability, and then to look at the health service pattern use, both before and during and after the more comprehensive health service deliveries that you've described. And I know, James, that was part of the evaluation of your own services, looking at the data through data linkage. We may have better capacity once we have a national disability data asset to do that in a more meaningful way, but there are local solutions to that as well that people can explore. I think we're going to be running out of time before too long. I would like to ask one more question for our panel, and that is whether or not anyone has any further developments or exciting next steps that they're planning, that they are willing to share or able to share for the next steps that they may take. Maybe if we go in reverse order from the east to the west, starting with James, then Merryn and Stephanie, if you're able to share any thoughts there.
I've got a lot of ideas. There's a few of them formed into reality at the moment. The one thing that we are doing is working in the forensic sector. There's an awful lot of people with intellectual disability in jails in New South Wales. There's a lot of data that supports they're overrepresented. So we have a forensic psychologist on the team now, and we're working much more closely with all those organisations, the Justice Advocacy Service, Community Safety Programme, lots of different people that work in the forensic system to try and get people out of jail. Really, they just seem to get stuck because there's no real great pathway onwards. And so that's a really exciting area, and one which I think having that specialist intellectual disability knowledge can make a huge difference.
It certainly can. Thank you, James. Merryn?
Yeah, what we're doing at the moment is just ensuring that we maintain a place for innovation and collaboration. So we're in the final 12 months of our 2 funded projects, and I guess it's an exciting time to apply learnings and as we enter a stage of implementation. But I guess it's what we have been trying to do as an organisation is just ensure that there is space to continue to engage in innovative and research in this space. So we have grown the disability portfolio, which had allowed us to bring together operational specialty services, disability strategy and projects, so that we're able to work collaboratively together. And we're now in the process of establishing some disability governance to ensure that we have that space to collaboratively work together. And that's included establishing an intellectual disability group so that we're able to ensure that we work together as an organisation and with additional stakeholders as well.
Thank you, Merryn. And Stephanie?
Yeah, we've got a couple of key things, I guess, coming up that are our priorities. One of those, we've got a statewide steering committee that's been supporting the implementation of our model of care here in Adelaide. And we've got 3 key priority areas that we're still focusing on, those being transition pathways for people transitioning between paediatrics and adult services, as well as hospital avoidance strategies and better integrated mental health service pathways. So they're kind of our key priority areas that we're hoping to be continuing to work with various stakeholders from across the state to try and improve things for people with ID here in Adelaide. And I think the other key area for us will be, as we approach the end of the 5 years of the proposed model of care, a review period around this is what we thought was needed for this service and this population. Now that we're in it and doing the work, this is what we've learnt and this is what we know is needed, and we're aware that there are still these gaps in healthcare that we need to continue to address, and hopefully we can be informing lots of those things with some research and some key data to underpin that.
Thank you, Stephanie. Stephanie, James and Merryn, this has been a real cracker of a session. You've illustrated so well how you have very specific context in which you're working, and you're speaking to that in terms of the clinical service models that you've developed and the research and evaluation components of that. Thank you enormously for your contribution. I'm sorry we're short of time. We could have talked forever. We had more questions than we've had available time. So thank you so much for sharing those insights. I hope that's been encouraging to our audience today. A real feast of what's possible, and an excitement, I think, that it's certainly possible to do things better and to really evolve our health services if we have a passion to do so. And you've certainly illustrated that passion in the places in which you work. So thank you so much for your participation.